Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note that we are recording these sessions for future distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be the facilitator for this session. To help us with attendance, please enter your name, affiliation, and email into the chat function. To access the chat feature, click on the speech bubble icon at the bottom left of your window. To all the Be Well Texas providers, please make sure that you identify yourselves during the session, or if you're joining via phone, please email your phone number and name to bewelltx@utisca.edu. Some housekeeping. Please stay muted unless you're speaking. If you joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, please press *6. We encourage you to unmute and speak, especially in the discussion portion of this session. We want to hear from as many of you as possible, so please keep your comments brief so as to allow time for others to speak up. Or if you'd prefer, you can use the chat feature to share your comments and questions. Please note that no predicted health information is allowed in either the chat or the discussions. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on More at the bottom right corner of your Zoom screen to find this menu. If you're having trouble accessing captions, please chat Echo IT. Towards the end of the session, the Shout Texas Echo team will send out a link to the evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on transitioning patients to buprenorphine and will be presented by Dr. John Weems. Following that, we will discuss a case presented by Dr. Zachary Freeland. We'll start with introductions, followed by didactics, Be Well program announcements, case presentation, and open discussion. Thank you all for joining us today. In the spirit of all teach and all learn, we encourage you all to share your experiences, questions, and insight in today's conversation. And with that, we will start with some introductions. Dr. Ramesh.
Hi, everyone. I'm Dr. Jan Ramesh. I'm a hospitalist over at Dell Seton and a HEP member.
Thank you so much for joining us. Dr. Walker.
Hi, I'm Dr. Walker, Blair Walker. I'm with psychiatry and one of the hub members at Dell Seton Medical Center.
Thank you so much. Dr. Weems.
Hey everybody, I'm John Weems, internal medicine doc, addiction medicine specialist at Community Care Federally Qualified Health Centers, and at Dell, one part of the Shout Start Squad. Looking forward to today.
Thank you so much for joining us. Alana.
Hi, good afternoon, everyone. My name is Alana Bolton. I'm a program manager at Dell Med and the director of Shout Texas. Thanks so much for being here.
Thank you so much. Dr. Freeland.
Yes, hi, I'm Zach Freeland. I'm a hospitalist at Baylor University Medical Center in Dallas, and I'm the clinical champion of our OUD program. We're one of the Shout member sites.
Thank you so much for joining us today. And with that, we will move on to our didactics. Dr. Weems, whenever you're ready.
All right, can somebody let me know they can see it?
Yes.
Okay, great, Shreya, thanks so much. And then the stop time where we're going to transition to the cases, what time?
You have about until about 15 to 18 minutes, maybe.
Perfect, great,
Yeah.
sounds good. Welcome everybody again. We're going to talk about starting buprenorphine in this new era of fentanyl. The goal of the next 15-18 minutes is to try to offer like a little bit of a simplified way of thinking about some of the newer start strategies for buprenorphine. I'm going to use the word start instead of induction or initiation, because one of the big take homes I hope everybody has is these are life-saving meds. We should be using them. It's a little trickier now, but on the whole, most of our patients are not having a difficult time starting buprenorphine, and we know that it will cut their chance of dying in half once they're on it. So we're going to talk through what I hope is kind of a simplified conceptual model of how to think about some new trends in our field for starting buprenorphine. Let me see. So I got nothing to disclose. So the learning objectives are to start bupe in patients who are recently exposed to an antagonist, and the take home here is just start. The second is to start bupe in patients who are chronically exposed to long-acting full agonist opioids, and the takeaway here is go high or go low. So our standard induction of kind of going down the middle is seemingly less effective for some patients. And then finally, is to counsel and support patients in choosing between these different options. So just as a quick level set for everybody, so we got 3 FDA-approved meds here in the United States for opioid use disorder. The first 2 on your left, methadone and bupe, cut mortality in half. Naltrexone can also be a very good option for some people. It does not have the mortality advantage that's been demonstrated yet. And that's what we're talking about. How do these meds work? So this is kind of a simplified, very simplified receptor model for how these medications help our patients. The first with methadone, which you'll see there, is the methadone totally fills the cup. So it is a full agonist. When people are on methadone, they have a full agonist effect in the way it's filling the cup there. So the way it looks here, and we'll look at it a couple of different ways. Next is bupe. So bupe's a little bit different. The way that's represented here is that it's buprenorphine is a partial agonist that is filling the cup, but not entirely. Another way this is talked about is that it's a net that kind of covers the mu opioid receptor. It blocks other opioid molecules from reaching that receptor. And intrinsically, in and of itself, it only partially activates that receptor. So that's the difference with bupe. Whereas naltrexone is a blocker, straight up blocker, stopping anybody else from getting in and talking to that mu receptor. So that's one way of thinking about it. And then this is kind of like the figure we're going to use today to think through cases. This is something I drew today for a patient this morning, and I draw out for patients all the time, and I think can help you think through some of the challenges we have with starting bupe. This is the same 3 medications represented on this graph. It's like super simplified. It's dose on the x-axis and mu opioid effects on the y. So in the green, you have represented full agonists, and the slope of that line is dictated by potency and a lot of other things. But the general concept is the more you take, the more effect you have. So it's going up and to the right. And that's true for methadone, heroin, and fentanyl. And then bupe is different. Bupe is a partial agonist and has that ceiling effect. So that's represented by the leveling off of that blue line, where if you continue to increase the dose, that ceiling effect, particularly for respiratory suppression, is extremely functional. You can keep giving the medicine and you're not going to run into respiratory effects in the same way you do with other opioids. And then the antagonist is represented there along the x-axis. It's just you're not having any opioid effects in most of the clinical doses we use. I'm throwing a line there because I think it'll help with the case, but like you don't reach that line of respiratory depression in adults who are physically dependent on opioids taking buprenorphine. You can run across that with other full agonists. So this is kind of the conceptual model. We'll revisit it a couple of times. Let's start with a mini case. We're going to do 2 mini cases. Remember, our learning objectives are starting bupe after antagonists and starting bupe in the setting of long-acting agonists. So first, we're doing antagonists. So this is a real case. 28-year-old houseless guy who injects drugs, has opioid use disorder, had recently been displaced from downtown camp by the library, was found unresponsive outside of the emergency room. These are initial vital signs that deteriorated, and he got hypoxemic. So the way to think about that using this simplified conceptual framework is he is on a full agonist of some kind. We're not sure what it is. We have to presume it's fentanyl in our environment. And so he's traveled up and right along that full agonist curve, and he's crossed the threshold of respiratory depression. And the vital sign we had was he's hypoxemic. So he's not exchanging oxygen enough to get oxygen around his body. And his current status is represented by that red brain looking thingy, that little icon there. So what do we do when that happens? We administer an antagonist. And so in this case, naloxone was introduced intranasally, and his total state of opioid agonism drops down to the bottom. The way that shows up clinically is this really high CAL score. And then in this particular case, the patient was able to consent to starting buprenorphine. Now, this is really important. Whenever we're starting bup, especially for patients who are already on other MOUD, methadone, and naltrexone, it needs to be an informed consent to switch over to buprenorphine. And an overdose in and of itself is not an absolute contraindication, particularly continuing methadone. This person said, you know, I've been taking bup intermittently, and I'd actually like to get on it. So can we use buprenorphine as a rescue after somebody has received an antagonist? And let's review a couple things about buprenorphine pharmacology. It's a partial mu receptor agonist. And the way you get there is with low intrinsic activity and some biased agonism, which we'll talk about maybe another time. There's very high receptor affinity. So that's the other key piece in this case. And in all of these cases, that bup sticks so tightly to that mu opioid receptor. Whatever your metaphor is, it's like the most, it has the highest affinity. So if it's glue, it's the strongest glue. If it's attraction, it's the strongest attraction. It is super sticky, and it's actually going to get it's going to get up to the opioid receptor even tighter than naloxone in most clinical cases. That's the way to think about it. And then it slowly dissociates and has a longer half-life. So the way I think about this case, this guy who overdosed and is in the ED, is stop thinking about the full agonist. There is still, whatever was in his system before is still in his system now, which is important to know for managing that overdose. But if you're considering a buprenorphine rescue, just do it. You're going to bring his total state of opioid agonism up from like as low as Narcan brought him back up. And that is likely to be experienced as relieving withdrawal. This has been, this protocol is used by a number of our paramedic EMS colleagues. This is really a contribution to the field of a lot of these teams reporting on using this protocol. It's more widely used in emergency rooms now, and I encourage everybody just to do it. If somebody's been recently administered an antagonist, get them going on bup. Now, what do you do if that's a long-acting antagonist? So this is from the Vivitrol website, the trade name for extended release long-acting intramuscular naltrexone. And what you have here is in the gold, you have the serum levels of naltrexone after administration of oral naltrexone, they're in gold. And over the course of the month, it's up and down and up and down. Whereas with intramuscular naltrexone, you have an initial peak and then a slow sustained release that can be really advantageous for a lot of our patients. For opioid use disorder, that is the type of naltrexone we use. So when would you start buprenorphine for somebody on naltrexone? Well, if they're on oral naltrexone, if you look to the left of your screen, the golden arrow, you start it like 24 hours after taking oral naltrexone, right? Because it is leaving that person's body. And you want to remember that this person, if they're taking naltrexone, they have no tolerance. So you want to start low and go slow, typically. So that's when you get it going. That doesn't happen very often because we don't recommend oral naltrexone for the treatment of opioid use disorder. In most cases, the vast majority of cases, people are rather on the long-acting injectable. So when would you start? So if tip 63 and SAMHSA would say on day 28 or 30, the ACAM guidelines hold the same. I think in an era of fentanyl, where return to use for somebody with no tolerance is extremely dangerous, this conversation should be happening earlier. If a patient is interested in transitioning to bup, we know that the serum levels on day 21 drop substantially. And so some patients with both alcohol use disorder and opioid use disorder, they get injections every 3 weeks because of that drop off. And that's the time to consider starting bup. A lot of time these conversations are happening when a patient is already not doing well. And so you might need that person might need a lot of support, a lot of touches with the team, and a more aggressive approach. In the inpatient setting, you can start with higher doses of bup. You can carefully monitor them. Again, it's exceedingly rare to have a monodrug respiratory suppression from buprenorphine. So if there are very strong cravings, if somebody's even already returned to use, be aggressive and think about starting on day 21. All right, takeaway, just start after antagonist exposure. Let me pause real quick. Any questions there? I learned this from a paramedic and I had a hard time at first with it. Chris Velasquez, you want to unmute?
Yes, Doc, I have a question. So does the does the length and amount of use, is that a consideration a factor for the protocol of the buprenorphine administration? Because I guess what in my mind is a person with 20 years of use is not the same person as 1 year of use, or I guess the dosage amount.
Totally, yes, great point. I think especially in the second case, the chronicity, frequency of use does need to be considered. When we're starting buprenorphine, the things that matter the most are what is the identity, as far as you can tell, of the full agonist they're taking? Like, how potent is it? Is this an oxycodone person? Is this a fentanyl person? Or is this somebody who's using like kratom, which has less intrinsic effectiveness? And then the chronicity, the most important thing is whether or not they're physically dependent. I hope that helps answer your question. In the first case, it doesn't matter if somebody's physically dependent already and they get an antagonist. This is how to think about it. They're at the bottom. In terms of their mu opioid effect, give them buprenorphine and get them up. If they're not physically dependent, you might have to start low and go slow.
Yes, Doc, that's answers my question exactly. So the biggest fail point that we had in the field, I'm sorry, I retired San Antonio Fire Department 27 years.
Awesome.
I was a program administrator for the MAP program and the T-TOR program. The biggest fail point we saw was that it was a substantial use of opioids, and we took them from that very high use to a partial agonist, and that, you know, that was a fail point for us.
Yes. And I think, Kristen, a lot of us are struggling with that now too, and that's actually a great segue going to the second case, is because fentanyl is so much more potent. And that's why I try to frame this talk in kind of two ways, like what happens after an antagonist, and then what happens when somebody's showing up and they've been exposed to a really high potency agonist for a long time. What are we going to do? And that's kind of the case here. This 38-year-old woman, this is from an old colleague, John Deweese's published case of a woman who came in with osteomyelitis related to injection use. I've changed up the details a bit here. As often happens, this is a patient who was doing well on methadone, and it stabilized at 140 milligrams, but more recently, for other reasons, it destabilized and is now using both IV fentanyl and methadone intermittently with the clinic. And she is admitted to the hospital and says she wishes to begin buprenorphine. So I think, Chris, I hope this has some analogies, some of the cases you guys were seeing. And you know, when I was like a fellow and I see somebody on methadone and fentanyl, the most important thing is to have an informed consent conversation around coming off of methadone. Because if she got her life back at 140 milligrams, maybe the conversation is, how do we help you get your life back again? And does that involve methadone? If she's making the decision to get on bupe, then it's a little complicated. So I think a simple way to think about it is like, she's on a long-acting full agonist. She's just on two different ones, methadone and fentanyl. The thing we want to avoid is, like what Chris brings up, is if you take somebody from that higher state of agonism with a traditional buprenorphine induction, you can drop them down real quick to the level, to that ceiling, to buprenorphine ceiling. That's precipitated withdrawal, and that's absolutely what we want to avoid. Why is this so tough right now with fentanyl? A couple clinical considerations with fentanyl's pharmacology. Up front, the big risk to our patients is fentanyl is high potency, there's unpredictable composition, and it has high lipophilicity. So what does that mean? Rapid onset, so it crosses that blood-brain barrier quick, and people overdose within minutes. It has rapid off, so that's a problem for injection-related injuries and illnesses. People have to use more often to feel well, especially at the beginning, and so we are seeing an uptick in the number of injection-related injuries, infections. And then here's the key thing for bupe starts. With chronic use, there's this reservoir effect where, because fentanyl is lipophilic, even pharmaceutical fentanyl, but also the stuff on the street, it sits in your fat cells and then slowly leaches out over time. So there's sustained high serum levels of fentanyl for a long time. And it is highly variable between our patients, like how much is in their fat and how long it takes to come out. And this has made it challenging in some cases to do buprenorphine starts. I should pause here and say a lot of our patients do just fine with the standard starts, but a lot of them are truly, truly struggling to get back on this life-saving med. So when we think about methadone, when I'm just teaching about methadone straight up, the first thing is that it has a long variable half-life, which is not so different from somebody who's chronically exposed to fentanyl. There's other things you need to take into account with methadone, but for the purpose of this conversation, I encourage you to think about them similarly when we're starting buprenorphine. The traditional start from methadone to buprenorphine is informed consent and then gradual reduction down to 30 to 40 milligrams. That takes months for somebody who's on a therapeutic dose of methadone, which is usually north of 80 milligrams and are probably north of 100, 120. And so that doesn't happen in the hospital, right? When you have emergent situations, things have to go quicker. And then the advice is to stop for 24 to 36 hours or even longer to allow for a washout period. And then symptom monitoring, typically with CAL score, and then initiating buprenorphine at low frequent doses, typically 2 milligrams throughout the day. So that's the traditional methadone to buprenorphine transition. The way to think about this in like using that same conceptual model, I lost my little stop sign there. So that green thing is supposed to be a stop sign. So basically, if somebody's on a full agonist, you stop it for a while, their state of mu opioid effects drops down below the buprenorphine partial agonism ceiling, and then you start bupe and they feel better. And that's the conceptual model for a traditional start. One of the suggestions, like how do you deal with folks who, like our patient who came in on methadone and fentanyl, or folks who are taking fentanyl all the time, is to take the concept of the traditional start, which was best for short-acting opioids, had a relatively short washout period, longer for methadone, and then maxed out typically 8 to 12 milligrams on day one, and you make some modifications to that. So it's the same conceptual model. It's this stuff still. You're stopping the full agonist totally, and then you're waiting long enough. And the first modification is wait longer. So just wait for a higher CAL score. A lot of patients, that suffering is intolerable and they're going to return to using. And so this carries risks, this particular strategy. You want to use all the adjuncts to get them there. So that's a kind of a separate conversation, but a much more aggressive approach with adjunctive medicines. And in modifying the traditional protocol, that's to prolong the period of opioid abstinence until it's totally washed out and you can start bupe. Another modification is to use more frequent dosing for a higher total daily dose, including considering using more than 32 milligrams on day one, especially for patients who are on high doses of methadone or have significant fentanyl exposure. This is a movement in the field that has happened in the last year or two. Really, I think some kind of trailblazers were doing it earlier, but there's more and more consensus that our patients are going to need more than at least on the first couple of days, and they might need later in their stabilization phase on bupe, and definitely more than we used to use in order to meet the opioid debt that is established by chronic fentanyl exposure. A second option, variation of the first, is the high dose bupe start. So this is another innovation from our colleagues in the emergency department that had a recent publication, Dr. Snyder and colleagues. That's sort of starting at the bottom of the slide. Sorry, guys. They showed that more than 98% of bupe starts happen without precipitated withdrawal and no sedation using this protocol. It's pretty simple. It's kind of getting a physical exam that verifies there's at least one objective sign of withdrawal and a CAL score greater than 8, and then starting with a high dose of bupe, not messing around with 2 to 4, 12 plus right off the bat. It's fast, it's simple, and it's likely to quickly treat withdrawal and maximize the agonist effect of buprenorphine. So you're rapidly getting bupe on board and displacing whatever existing at other full agonists are. You're getting the bupe dose right up. So that's the high dose bupe start. That there is, this is the level of evidence for this is retrospective cohort studies, but it's very impressive results from what the California Bridge team published there, Dr. Snyder. Variation on option 1 is option 2. Option 3 is totally different. So this is microdosing or low dose bupe starts. And this is complicated in the outpatient world, is less complicated in the inpatient world. And here's the general concept. So what you see at the top is precipitated withdrawal. The golden the little figures there, that represents other agonists. And then you add enough buprenorphine at a high enough dose that you totally displace those. And within less than an hour, you have rapid clinical change and people feel terrible. That's precipitated withdrawal. The conceptual model for low dose inductions is bridging at the molecular level, so it's called here by Ghosh and colleagues. So you're slowly introducing low enough doses of buprenorphine that you're minimizing the antagonist effect. So another way of talking about this is induction without withdrawal, or starting bupe without withdrawal, because you're slowly enough introducing the buprenorphine that it's not experienced as a rapid decrement of their total opioid agonist state. So that's the idea with low dose bupe starts. This is what it can look like. So this is Dr. Sean Cohen out of Yale has made this available. And I show this to patients to say, this is kind of complicated. We're going to support you through this and walk them through slowly introducing, and this is what it looks like. And then just to have like a frank conversation. Does this seem like something that we could do together? And the things we're thinking about are, is this person stable enough? Do they have support? And are they on board with doing something that's quite a bit more complicated than our traditional bupe starts or a high dose bupe start? The other thing I'll point out about this how-to from Dr. Cohen is that the full agonist continues throughout the duration of microdosing or low dose inductions. The most common mistake with low dose inductions is rapidly tapering or stopping the full agonist. You have to keep going with the full agonist. These are some principles, again, thanks to Dr. Cohen. One is the appropriate clinical situation, and that's long-acting full agonists like methadone and fentanyl, people with acute or chronic pain. That's where this protocol is kind of pioneered. And then patients with prior precipitated withdrawal and who aren't interested in attempting a traditional start. When you're doing it, you start low and go slow. Dose is definitely less than 2, but typically less than 1 milligram sublingual or its equivalents. If there is withdrawal, you pause. And my colleagues who do a lot of this on the East Coast, this is taking weeks in some cases. You really want to work with the patient and walk with them through this and have flexibility about the timeline. You must continue the full agonist. You must continue the full agonist, which is a very tricky counseling conversation when our drug supply is poisoned, and that puts our patients at risk of overdose and dying to continue non-sanctioned drugs from the street. So we also want to couple that with harm reduction counseling and plugging them into community can help care for them. And then frequent clear communication and coordinating care. So again, thanks to Dr. Cohen for these principles. For the sake of time, I will skip through this. This is again from a narrative review that I cite there and can send out to folks. It's really helpful to have different ways of talking to patients about this. One way is to talk about a car that is gradually slowing down instead of slamming on the brakes. Slamming on the brakes to start bupe. We will skip past some of these challenges, and I think we're close to time. So that's it, y'all. So that I hope that you're walking away with a pretty simplified conceptual model of starting bupe in the era of fentanyl. If somebody's been giving an antagonist recently, just start the bupe. If somebody's coming in with full agonists on board, either go high with those modifications to the traditional protocol or a high dose start, like it's been pioneering in California, or go low and do a low dose start strategy. It's quite a bit more complicated, but can be a very effective way to get folks onto bupe. The final takeaway is, like with more options, there's more space for patient experiences and perspective and preferences for how we do this. It's one thing to just have a one size fits all approach and say, this is how we start bupe here. I think we're living in an era where that's not working for everybody. And it really is an opportunity to try to center our patients and how we make these shared decisions. So some counseling take homes, in particular, talking about these different bupe start options. Let the patient guide careful planning. Which one do you want to do, and be clear about that together. And then reassurance, we're going to get through this together. And especially for my hospital-based colleagues, invite the supports in. Just like any difficult procedure, if your patient's about to undergo it, make sure that if a loved one is available, they can help the patient think through this and be a part of that decision. The other key role here is recovery coaches and then other recovery supports. So people who have lived experience are going to be able to support our patients through this in ways that I don't have that ability as a physician. And don't forget the adjuncts. The last thing is, no matter which strategy you're using, I think we've got to be way more aggressive in how we use adjunctive medications to help our patients get through it. So that is all I got. Unshare my screen. Great.
Thank you so much, Dr. Weems. That was a very, very informative presentation. I believe we have time for maybe a couple of questions from our learning community here. So we'll open up the floor for any questions or comments, or maybe experiences trying out these.
I have a question. I just want to validate my practice. So you have someone who says they haven't used in 24 hours and you'd start your induction. We do high dose induction in San Antonio and 16 milligrams. And she goes into precipitated withdrawals. So either she has some long acting stuff on board, she used and didn't tell us, or whatever it is. So what we've been doing is actually doubling down and just giving another 16 immediately. And that seems to work. So we don't, in 4 years, we've had like 4 or 5 precipitated withdrawals. But for me, it seems like doubling down really gets them out of trouble quickly. And this morning I saw her and she has a COW score of 0. So.
Thanks for sharing that for all of us to hear. You guys have a length of experience with this and that's working well. That is in line with what others are using. If you're managing precipitated withdrawal, the things to know, like that the good doc just shared, is like, it's rare. It does not happen very often. In that JMR, it's like less than 2% of cases. It does not happen very often. And the answer is going to be more bupe. It's easy for us to say as docs, more bupe. Takes a whole team walking with a patient and holding their hand, rubbing their back and talking about, you can do this, you can walk through it. Being very careful about administration and precipitated withdrawal. One of the big challenges is the sublingual, making sure that, especially if there's GI distress, that somebody's leaving it under their tongue. And sometimes some of the other formulations can be helpful in that case. And then Dr. Mirmaz, are you guys using adjuncts in that case too? If you think you're dealing with precipitated, are you guys using short-acting benzodiazepines or other strategies to help keep patients retained for the remainder of the bupe start?
So we pre-med, we give them 8 azofran, 25 of Benadryl. If they give them a gram of Tylenol for pain, if they're having diarrhea, we give them 2 Imodiums. So we have them take the oral meds first, because after you give bupe, they can't drink for 15 to 30 minutes, right? So you can't med them afterwards because you're going to screw up your bupe. And then we give them 16 sublingual bupe, and then we watch them while we're doing all the paperwork and getting the taxi voucher and getting them referrals and going through all that stuff. And then if they need more, then we add 8 or add another 8. But I just wanted to share that precipitated withdrawal, because it's real scary for my paramedics when that happens. Like, oh my God, I made them sick. And I'm going, okay, give them more. And they're like, you sure, doc? I said, yep, give them 2 more. And it does work. I just wanted to make sure that people know that they do have this 2% chance. You're not going to kill them. They're not going to have to go to the hospital. You can manage them. Just give them more.
And it's Blair. I almost always kind of cope ahead with my patients and coach them about that plan too. Like, hey, this is rare, but if it happens, we just give you a whole lot more and quash it away. And then they've heard it before it happens so that they're prepared and don't go, what? I'm not taking that again. So I think that's another thing to like remind the patient that if it happens, probably not, but if it does, that's what we're going to do. And it goes over better.
Thank you. Chris?
Yes, so Dr. Weems and Walker, have you all had any success or any efforts towards tramadol as kind of a step down from an agonist to tramadol to maybe bupe? Or I'm talking about, these are people with 20-year problems. That this is not to keep harping on the subject, but I love the approach of remain on your agonist. I love that. I mean, because that's one of the biggest hurdles in San Antonio and surrounding areas. They go to a clinic or a facility that's going to be the administrator or the person that's going to keep them on long-term bupe, but they get tested, methadone and bupe. They get tested for any kind of usage prior to administration. So, but I think that approach of small stepping it into larger doses of bupe and kind of just converting them over, I think that's a huge approach. I love it.
I'll say in the medical hospitals, which is what I do, I mean, it's pretty standard now across the country, especially if you're trying to transition and you have time, between chronic daily fentanyl to Suboxone or buprenorphine. Opioid bridging, so to speak, is a pretty common practice, especially if you're dealing with somebody who's also dealing with some acute pain as well. So we do that all the time. I would say I don't use tramadol in particular. I use other agents, but there's certainly a role for using another opioid in between, especially with fentanyl. I don't know if with other opioids it's necessarily as indicated. Maybe if you're doing a methadone switch, since it's just kind of complicated. I don't know if, John, you have other.
Look, our colleagues in the North use sustained release oral morphine. There's like pharmacologically, it's not like it makes a ton of sense to do that, especially for microdosing in some of the early case series. You can see exactly what the doses are, and it makes a ton of sense. We haven't figured out the regulatory way forward for that in the United States, and so we're fairly limited in the outpatient setting to doing that. I think you're right. I hate tramadol, tramadol. I'm a big, I worry about a lot of the medical complications with tramadol. So try to avoid it. Some people benefit from it. And there have been a couple case series published of tramadol's use in opioid withdrawal management. It's just outside of the US again, because of where we're at with regulatory stuff. And just to echo what Dr. Walker said, when patients are coming in with pain to the acute setting, treat their pain. And that often means opioids at higher doses than we're comfortable using. Start thinking about 2 to 3 times the normal starting dose for patients with clearly established dependence and tolerance, and go up rapidly from there to try to retain people in treatment and deal with the suffering they're coming in with. And especially with microdosing or low dose inductions, and we have tools on the back end once they are on full agonists, predictable full agonists in the hospital, to transition them safely to buprenorphine if they wish.
Thank you so much. In the interest of time, we will move on to the next part of our session. Carly, if you could please bring up the program announcements. The Center for Substance Use Training and Telementoring provides high-quality education to healthcare providers. CSTAT makes evidence-based practice available to addiction specialists in Texas and the US with sessions like the one you're attending today. For more information, please visit bewelltexas.org. Next slide. I'm sure many of you know already, Narcan has now been approved for OTC sales. Please be on the lookout for more information about the new guidelines in one of our upcoming sessions. Next slide. It's the time of the year to renew our series. You should have received a separate notification from Zoom that will provide the dates for the upcoming sessions. You just need to download the calendar, and that's it. That's all you need to do. So please watch out for that email. Next slide. Getting your CMEs is very easy right now. So please text the code 100-928-37 to the phone number here, and you should be by midnight today. This information will be also dropped onto the chat. Next slide. Please join us for our next Shout Echo, which will be on Thursday, May 18th. Thank you. And with that, we will now move on to our case. Carly, please share the case, and Dr. Zachary, you can take it away whenever you're ready.
All right, thank you. So this is a case we took care of at Baylor. It was actually last fall. And it's kind of a chaotic case and not one I'm particularly proud of, but I think it meshes well with the talk by Dr. Weems, and hopefully we can learn from it. So the questions that I wanted to see if we could get answered are, and Dr. Weems may have kind of partially answered this first one already, but what are our options when a patient continues to experience withdrawal symptoms despite maximum dose, which we traditionally call 32 milligrams a day of buprenorphine? And then what frequency of QT interval monitoring people think is necessary when initiating and titrating methadone? And finally, whether anyone's had any success in getting undocumented patients into OTPs. So this was a 36-year-old woman with history of injection drug use and homelessness, who presented with kind of non-specific complaints, nausea, vomiting, diarrhea, and just feeling unwell for the past couple of days. And she initially attributed her symptoms to being in withdrawal, but then she turned it out to be septic and have a pretty significant community-acquired pneumonia. So her medical history, she had chronic hep C, several ED visits and admissions for various skin and soft tissue infections related to injection, history of scabies, pyelonephritis, and had 2 prior C-sections. Was not taking any prescribed medications. In the hospital, she got kind of a whole slew of antibiotics. She was, and we'll talk more about this, but she was tried on buprenorphine as well as methadone at different points in time. And then also got some adjunctive clonazepam and clonidine. So social history, so she started snorting heroin when she was in high school and eventually transitioned to injecting heroin and then fentanyl. At the time that she got to us, she was pretty confident she was using basically exclusively fentanyl. She also endorsed smoking crack cocaine. She had previously been on methadone, 85 milligrams a day through an OTP several years prior, but was not currently on any kind of treatment. She was living on the street. She said that because of how frequently she needed to use, she wasn't able to get in and stay in shelters. And she was pretty vulnerable, so didn't have any stable source of income, did not have health insurance, did not have any support system. Her parents were her closest support and they lived out of state. She had 2 young children, but was not at all involved in their lives. She did admit to having sex in exchange for either drugs or money, but denied having anybody who controlled her. In other words, denied being trafficked. And this is going to be important later, but she did not have any form of ID and didn't have a cell phone either. She did not have any formal psychiatric diagnoses. So hospital course, so she was admitted for sepsis and pneumonia. Which is initially seen on chest x-ray, but then the subsequent CT revealed that she had like a big cavitary lesion in her right upper lobe. And so there was concern, is this a pulmonary abscess or is this tuberculosis? And she was put in isolation and ended up being at the hospital for about 2 weeks while we sorted all this out. She was found to have HIV with a kind of lowish CD4 count, but a very high viral load. And this was thought to be relatively acute infection. She was also screen positive for syphilis and was treated for that. She was treated for her pneumonia and she started on prophylaxis, given her with Bactrim, given her low CD4 count, and TB was ultimately ruled out, fortunately. So our team, so we have at Baylor, we have an OUD team that's comprised entirely of hospitalists. We don't have any addiction psych or addiction medicine specialists. So we were consulted on the day of admission, and there's kind of a lot of uncertainty initially because she, just kind of eyeballing her, she seemed to be very uncomfortable and seemed to be in withdrawal. But there was just kind of very labile, and at times she'd be just like kind of unresponsive, not like obtunded, but she just would keep her eyes closed and wouldn't talk to you. And so it was hard to really gauge the degree of withdrawal, but we felt like she was in withdrawal. Dr. Weems talked about with patients using fentanyl chronically, either going high or going low. We decided to go high. So gave her 8 milligrams right off the bat of buprenorphine, and ended up giving her a total of 4 doses, so 32 milligrams on the first day. And she was not happy with that dose. And we kind of stuck through it and continued that for another day or two of 32 milligrams a day. And it didn't seem like it precipitated withdrawal, but she was just very, very uncomfortable and kind of climbing up the walls and kind of saying that she was going to leave. It's clear that she knew that she needed to be in the hospital and wanted to stay, but she was miserable. And so on the third hospital day, we finally agreed that this wasn't working. We need to try something else. So we transitioned to methadone. We gave her 30 milligrams initially, and then another 10 milligrams that first day. And then over the next couple of days, titrated up to 50 and then 60 milligrams. And on 60 milligrams, she actually did really well. She was comfortable. She wasn't over sedated. She was cooperative. We got her kind of infectious issues sorted out, and we were nearing readiness for discharge, and kind of it came to our attention. We're talking with our case managers about trying to find her a methadone clinic where she could follow up, and it came to our attention that because she didn't have ID, none of the clinics said that they were able to take her and do an intake and dose her. And so we, like our case managers, I feel like really did their due diligence. They tracked down her parents, and parents were able to find a birth certificate, and they FedExed it. But it was clear that she was not going to be able to get the resources in Dallas for patients to get, for indigent patients to get assistance with getting photo IDs. But this wasn't something that was going to happen in the hospital or in any kind of timely fashion. And so we felt that discharging her on methadone without any sort of follow-up plan would be irresponsible and not doing the patient any favors. And so we convinced her to let us try the buprenorphine again, so that we could at least prescribe it, and that would buy her a little bit of time to get into, I think our plan was actually to have her follow up with Parkland Homes program. And so she was agreeable to that. And so we stopped methadone, and after about 72 hours, she was in withdrawal. I couldn't find her exact CAL score, but it was over 13. And we managed her withdrawal with adjuncts, with the clonazepam and that I mentioned earlier. She got some Tylenol as well, but it really wasn't as rough as we anticipated. And so after that point, we went ahead and started buprenorphine again. And this time we went with the low dose approach. We started with 2 milligrams that didn't precipitate any withdrawal, and titrated that up to 12 milligrams over the course of the next day or two. And kind of bizarrely, we got her stabilized on 12 milligrams. And she felt good on that, whereas before we had not been successful with 32 milligrams. And so this raised, I'm kind of jumping ahead here, but this raised the question of whether she may not have been taking the buprenorphine correctly initially. We've kind of subsequently had cases where it was clear that the nurse gave the patient who wasn't familiar with buprenorphine or just didn't recognize the tablets, the little cup of pills, and said, here you go, and didn't explicitly tell them that it has to be given sublingually, and so they just swallow them. And so that, I don't know if we ever exactly figured out whether that happened or not, but that was one of the kind of hypotheses. I guess the other possibility is that maybe just now that we're 2 weeks into her hospital stay and kind of the fentanyl is finally washed out, and she was kind of on a middle of the road dose of methadone, that maybe all she really needed was that lower dose, and that we just needed more time for the fentanyl to wash out. So anyways, we ended up getting her stabilized. She was ultimately discharged, and it was kind of unclear. She said that her intention was to go move out of state to stay with her parents. I don't know if that ever actually happened or not. Yeah, that was the case. Just a couple of housekeeping things. The PMP we did review, and she had no entries. And then I think I talked about her other substance use history with the crack cocaine. She did smoke half a pack a day. And then prior substance use history or substance use treatment history was really just that methadone clinic. I don't think she had really been engaged with any inpatient or residential treatment or 12-step programs or anything else.
Thank you so much, Dr. Freeland, and we will open up the floor for any questions or comments. That was a very, very interesting case. Thank you for presenting.
Well, I can go back to those questions that I started with. I know the first question was about what to do when the patient is still having withdrawal with 32 milligrams, and Dr. Weems had suggested going up above 32 milligrams a day. Would anyone have done, I guess, aside from making sure the patient was actually taking the medication properly, is there anything else anything else anyone would have done in that scenario?
Take it or leave it. I think you keep taking the top off your review of bup, you continue to increase the dose, your review administration, just like you guys did. If you have it on formulary, Buprenorphine or injectable buprenorphine is an option. The doses you're talking about are not the doses that you are not where you could get with transdermal bup or butrans patches. So that's not going to help you here. I think you kind of went through the list, and in our fragmented addiction care system, we don't think enough, like you guys did, about like, what, maybe this isn't the med. What about methadone? Because of the challenges that arose in the second half, and one of that, maybe a reason that we don't think enough about is the challenge from the second half of the case. It's just so tough to figure out the back end. So I wouldn't have done anything different. I wonder though, I think the most important question to me is like, how did you guys establish the trust with this patient to go through this? This is an extensive inpatient course where MOUD starts. The remarkable thing to me is you guys stuck with it, and this patient stuck in the hospital and learned a life-changing diagnosis and had a life-threatening issue when they came in. So there must be something special about how y'all were able to engage. What's the secret sauce? What'd you do?
Yeah, I think it was a long hospital course, but I think our team was able to establish rapport with her. And it wasn't just me seeing her every day. There were at least 3 or 4 of us involved. I think we found that even though we're all hospitalists, and even though they're the main person taking care of their medical issue is a hospitalist, and we're part of the same practice, I think we found that kind of having those separate roles is helpful, and that when we walk into the room and we're wearing our OUD hat, it's kind of like we can put all the other stuff aside and just I feel like patients give us kind of seem to trust us and appreciate what we're doing when we're just kind of trying to make it clear that we're trying to meet them where we are, and just being kind of frank and honest with them.
Thank you. That's super helpful.
That second question I'd ask about the QT monitoring, the reason for that was that one, she was also taking levofloxacin for her pneumonia, and 2, she was intermittently refusing the EKGs because, of course, for the daily EKGs, they come at like 5 or 6 in the morning, and so she was intermittently sending them away. And I wasn't sure how worried I should be about, well, if we don't have QTC in the past 72 hours, do we need to stop methadone before we can get one, or is it not as big of a deal? I don't think she ever actually had a prolonged interval.
If there's any methadone mavens on the call, I'd love a chime, especially from anybody working currently in an OTP. What I can share is, there was I think it was more than 10 years ago, SAMHSA got a bunch of experts together to review what we know about QTC monitoring for patients on methadone maintenance doses of methadone. And turns out, like a lot of things in medicine, we don't know very much. And there's a lot of areas needing study. Generally, this is a population without pre-existing risk factors for prolonged QT intervals and without significant risk factors for developing torsade de pointe. And for people who are, non-provider folks, if your heart is pretty healthy, these rare heart effects of methadone don't happen very often. And it might be like case reports. So there's a lot we don't know. The panel was unable to come to a lot of solid conclusions about risk stratification, screening, and monitoring. And so that leaves us at a place where, and I'm rusty on my methadone updates in terms of like best practices. And I'll do some work on the back end to see if there's been more guidance on this. In general, we take too many EKGs in the hospital, worrying about QTC prolongation. Some of the things you named that I think are totally appropriate, like when you're adding another QT prolonger, really significant risk factor. And the most common ones for people admitted with infections like fluoroquinolones, but then also antiemetics. So she was barfing and stuff, right? So then you're using a bunch of meds that could potentially prolong it. And then she's barfing and stuff. So she has electrolyte abnormalities. So that's the other one. And if she had never had QT prolongation, despite all those physiologic derangements, I would not be as concerned, because if you look at the risk, like you guys do, and you have that OUD hat on and you go in, you can kind of take a global perspective and say, what's the risk benefit to this person's ongoing health and well-being to address their life-threatening infection, get plugged into the HIV continuum of care if they leave the hospital because we don't continue to up titrate their methadone or don't continue their methadone, versus we further pursue these potential, almost theoretical cardiac risks. That's for a person who baseline is a low risk. That's how I would frame it. If she has a history of passing out and nobody's ever been able to explain why, if a number of people in her family have dropped dead and have been told that they have sudden cardiac death syndrome, that's just a different thing. Or if they have a history of endocarditis and a dilated cardiomyopathy. So like your risk stratification matters. It makes sense to get EKGs when they're engaged in care. When you're adding medications, it makes sense to get EKGs. When the dose of methadone exceeds 120 milligrams, I think there's a little bit of consensus there that we need to monitor a little more carefully, typically a week or two after dose increases, when we think we've achieved steady state, and especially for those with enhanced risk. But that doesn't sound like her. So that's all to say, into the space where there's not much evidence, we throw a bunch of reasoning into it. And my reasoning was centered around her prior probability and the global risk benefit of engaging her in care, which I think you guys did pretty artfully.
Okay, that's fair. And then if we have, I know we're running short of time, but I just want to see, does anybody have experience getting somebody without ID, either an undocumented immigrant or just somebody like this who's homeless and just lost, their papers got stolen or lost? Because that was a big barrier in this case.
How to get them an ID, or how to get
how to get them into an OTP without an ID? Is that possible?
John?
I don't know. I texted some methadone colleagues here in Austin, and I'll follow up to the whole group next month, or if not earlier by email. It is significantly challenging. I think we're talking about a similar population that's marginalized in a bunch of different ways, and so it's no small thing to get an ID.
I've never heard that before. I've never had the method. This is Austin, and Kristen Escamilla is on here. Like, I haven't had anyone say, "Oh, I don't have an ID, so I can't get in." The methadone clinics who have helped us get people in, and John's clinic, I've never heard anybody say they've got to have their ID with them, though. I'd worry about the pharmacy and picking up the prescription. That is an issue, but I also wonder if they have like their hospital discharge. Here's my discharge thing. I don't know. Anyone with an ID can pick up their prescription for them if they have that person's birthday, though, especially buprenorphine, because it's Schedule 3. So I could pick their prescription up with my ID. So that is a workaround if they have someone with an ID to get their prescription. But other than that, I don't know. And the ID thing is always a problem when people really do have it required.
Yeah, we refer people to NTP, Matt, a lot, and I've never had the ID be like the rate limiting factor, like ever. And so I'm curious if it's more of like an agency thing. Huh.
Yeah, I don't know. I mean, we have
San
we have
Antonio,
2
right?
or 3 here in Dallas.
Oh, in Dallas, okay.
We have an ID issue in San Antonio, and we reach out to other philanthropy groups in San Antonio and surrounding areas such as the Haven for Hope. They have an ID recovery. The ID for the San Antonio area is not an issue for independent agencies, but it is an issue with clinics. That they have no form of ID, no form of anything. It becomes problematic when we try to induce them into a clinic for therapy or treatment.
Thank you so much. This has been a wonderful discussion, and we'll have to unfortunately cut short because we're at the end of the time. Dr. Weems, if you could please summarize. I know it's a lot of material to summarize, but if you could just attempt
I
a
think
quick summary.
the key thing from the case is this team was able to meet this patient where they were at and retain them in care using a variety of different strategies. And when you're thinking about starting bup, go high or go low, they went high, and the patient was retained in care, and that's the takeaway.
Well, thank
Thanks,
you
guys.
so much. Thank you everyone for joining us today at the ECHO session. As a reminder, to earn CE credits, please text the activity code 100928837 to 844-502-1338 by midnight today. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email bvaltx@yudhiska.edu. We look forward to seeing you at our next session on Thursday, May 18th. Have a wonderful rest of your day. Thank you.